In this video, we're looking into some of the key factors which influence prognosis of adductor-related groin pain, a common condition if you're dealing with patients with hip and groin issues. A bit of overview of adductor-related groin pain. So as you can see in the slide here, the pain is generally localized to the medial aspect. The pain is reproduced on the squeeze test. There's pain on passive stretching. We can palpate the pain, and weakness is common when you do strength testing with handle dynamometer. So that's a fairly simple condition to diagnose in clinic, and they generally do really well with graded rehabilitation. Now let's look into some key factors which is really important to explain to the patient about the prognosis and the duration of symptoms, especially when you're dealing with rehabilitation. First is the location of pain. So is the pain localized more towards the tendon insertion, or is it more on the myotonius junction? So that can vary, and that can have a big impact on the prognosis. If it's more towards the bone, and if it also has associated osteitis pubis, that can be a long rehab. It could be 3 months, 6 months plus. If it's more towards the myotonius junction, then it's the prognosis is generally fairly quicker than tendon. So again, location of pain can have a big impact on your prognosis. The second point to remember is, clinically, I find adductor-related groin pain comes in sort of 3 formats. So one is people with pure isolated adductor-related groin pain. Number 2, adductor-related groin pain with osteitis pubis, which I've talked in detail in one of the previous videos. And then adductor-related groin pain with intra-articular hip pathologies like hip OA, hip impingement, or hip dysplasia. So again, when you have a patient with chronic adductor-related pain, it's just putting them into these 3 boxes. Which of those 3 are you seeing in clinic? So generally, if it's isolated, they tend to do much quicker, whereas with osteitis pubis, it can be a much longer delay. And if they have intra-articular hip pathology, it could be similar as well. The third factor to remember, which is as mentioned in the slide, is patient-reported outcome. So using a score like the HAGOS, which usually tells us function from 0 to 100. So if you've got a patient with a HAGOS score of 80 and somebody with a HAGOS score of 30, that's a big difference on your starting point of rehabilitation. So with all my patients with adductor-related groin pain, I tend to use HAGOS, which gives me a good objective marker on the irritability and also the function, which is the key thing which you're looking at. So I generally tend to assess them every 4 to 6 weeks and see the progress, and the patient can also see when they first came, like the score was 35, 40, and then they can see they've progressed. So this is a good outcome measure to be using with all the patients. So in summary, dealing with adductor-related groin pain, what are the key 3 points to look at? Location of pain. Is it simple adductor-related groin pain or associated with osteitis pubis or hip? And the third is patient-reported outcome using HAGOS score. Thank you.